Dr. Terkawi. I'm an anesthesiologist and pain management fellow. Today, I'm gonna uh, present to you some principles in airway management, and will try to emphasize more in situations where we have emergency airway or we have an ICU patient. And since we live in the era of COVID-19 nowadays, I'm gonna touch base on that in my last few slides. So I have no financial conflict of interest. Today, hopefully, we will cover um, these 9 objects. And as you notice, actually each one of them per se um, need a lecture. And if you go to any book, you will find that indeed this these are separate chapters. So let's get started. So before we dig in on this anatomy section, I want to emphasize that this is very important for anyone who is dealing with airway, whether anesthesia, ER physician, critical care, you name it. What I'm gonna present here is just some nomenclatures, some very few things that will help us to speak the same language in the next few slides, but this is definitely not enough. You need to know detailed nerve supply, blood supply, everything about the airway. So you started by opening the patient mouth. You hopefully you will see this beautiful picture here with clear uvula, soft palate, hard palate, the tonsils, the tonsillar pills. Then you go all the way down and you see this vocal cords. So these are the vocal cords. This is the epiglottis and a bunch of cartilages here. Just remember, for the purpose of this lecture, remember the ariepiglottic fold or cartilage, because we'll see when we talk about grading the airway view, we're going to mention this again. This is AP and sagittal view in the trachea. Again, this is the epiglottis. See how it's attached to the thyroid cartilage. Then here we have thyroid cartilage, cricoid cartilage, and remember here the cricothyroid ligament, and then the tracheal rings. The hyoid bone, also it's an important landmark. This is classic adult trachea and main bronchi. As you probably all know, that the right main bronchus has different angle and slightly bigger and shorter than the left side, which explain when we have aspiration, when you have bronchial intubation, most likely you're going to the right side. And it's also important for you who is dealing with airway, not only to know the gross anatomy of the airway, but also you need to know some radiological anatomy. Specifically here, we're talking about X-ray, CT scan, and ultrasound, of course. So this is a classic chest X-ray. Here, you probably can see the carina, and then you see the endotracheal tube, just where we would like to see it, 2 to 3 centimeters above the carina. So that's briefly some airway anatomy. And then now we're going to talk about airway assessment. I'm going to spend most of the time in this lecture in this section of airway assessment. And the reason why I want to do that, because from my experience and from my observation, I found that most of anesthesia provider, or many of anesthesia provider, they really don't know a proper, they really don't do a proper airway assessment. I'm not even talking about non-anesthesia providers. Remember, we live in an era where many of the diseases nowadays get diagnosed by ultrasound, CT scan, MRI. But when it comes to airway assessment, really what you have is your vigilance in taking the history and doing a proper physical exam. So we'll give this a more detail here. So now you get called. There is an emergency intubation in the ED or in the ICU or in the floor, or you're just going to see an elective surgery for tomorrow, right? So what do you need to know? What are the important things you need to think about and make sure you cover while you are seeing the patient? So of course, let's start with history. So first of all, you need to know what's the indication of intubation, especially if you are going to do an emergent intubation. Is that because you want to protect the airway because of bleeding? Is that because of, again, upper GI bleeding, low GCS score, patient seizing, or is there a fracture? These are important things. Then you want to know whether the patient has some comorbidities, diabetes, heart failure, hypertension, ischemic heart disease, and so on. And then if you want to look at any history, do you definitely need to ask the patient this, or also look in the previous charts if you have access to that and see if there is any history of difficult intubation. Then check if there is history of cervical surgery, fixation, neck trauma, facial trauma, and of course, drug allergy, what you need to avoid, what you can use, and definitely you need to make sure the patient is properly NPO, especially if it's an elective intubation. While you're looking at the chart, while you're looking at the labs, don't forget to look at the potassium level, especially if you want to use succinylcholine. Look at the platelet, make sure the patient doesn't have any bleeding disorders. Coagulation profile, look at the kidney function so you know what you use, what you avoid. If there is an ABG, if there is an EKG, to look for any arrhythmias. And of course, if there is a chest X-ray or a CT scan, just look at the airway and see, do you have a normal infraglottic airway where you really cannot see, so you need to put your tube in and blindly, and you need to know, do you have a stenosis, do you have a deviation, do you have a mass, do you have any issue like that? And then when you go and examine the patient, first of all, as anything, you have to look at general examination. And believe it or not, the majority of difficult intubation can be anticipated and predicted if you do a proper history taking and thorough examination. The majority, even some references say more than 98%. So start by general examination. What are the vital signs? what's the weight of the patient, the BMI, the level of consciousness, any facial abnormalities, any cyanosis, what's the blood pressure, the heart rate, is there any abnormality in the spine? If you have a female patient, does she have a big breast that will make it challenging for you to manipulate your laryngoscope? Is she pregnant? And then we'll dig in deeply on the airway examination. You need literally to examine everything from the lips, the tongue, the oral cavity, teeth, temporal mandibular joint, nose, head, neck. And remember the general principle. You need to look and feel and listen. So still in history, what you also need to do, again, you need to see if there is any previous airway records. Ask the patient about any dental problem like chipped teeth, loose teeth, etc. Any respiratory diseases, specifically do you snore? You can use the stop bank to predict if the patient has OSA, asthma, COPD. Do you have arthritis? We are more concerned here about the TMJ joint, but if the patient has a history of ankylosing spondylitis, for example, or rheumatoid arthritis, then you might think, oh, this patient might have a TMJ or cervical arthritis. Clotting abnormalities, history of GERD, especially if you are planning to use an LMA, and just simply to ask the patient about the severity. Of course, it's important to ask the severity of the gastroesophageal reflux disease. So ask the patient, do you feel it at your stomach, or do you feel it in your throat when you have reflux? What medication do you take? How many pillows do you use to sleep in? So just to have an idea, because if the patient has a severe reflux, then probably it's not wise to use an element here. Any congenital anomalies, there are a bunch of syndromes that known to be associated with airway difficulties. Then if the patient has a diabetes type 1, it has been shown that almost 30% of insulin-dependent diabetes down the road, they develop some joint mobility syndrome. So this is a quick and easy test that you can do for this chronically type 1 diabetes, which called the prior sign. So basically, you are asking the patient to put their palms together, and you observe, mainly we're talking about the fifth and the fourth interphalangeal joints. They, as you see in the picture, they don't touch each other. So someone can postulate then that this patient has some joint diseases, and you can postulate that to the TMJ joint and the larynx and cervical spine. Similarly, people took this farther and came up with the palm print sign, where basically you put the palm on ink and then put it back in a piece of white paper, and you look at the imprint. There are some small studies that showed that this is better predictor than just a prayer sign, but as you can imagine, it requires some time, and it requires you need an ink, but the prayer sign is just a simple thing you can do. Then going to the airway examination, to start with, you look at the mouth. So when you open the patient mouth, it's not only about Malambati. we're going to talk about Manabati now. It's literally, you need to look at everything. You need to look at the teeth, the tongue, and ask the patient to flip the tongue and look at the floor of the mouth. So this is called tori. These are very rare. I have seen it one or two during my residencies, and but they are well known to be associated with difficult intubation. So while you are opening the mouth, you can also look at the teeth and do the Manambati examination. It's important also, sometimes you enter the room and you look at this and you see this tongue. So this is, as you can guess, this is angioedema. So this is, again, this is an emergency thing. So you need to stop, call for help, probably call a backup ENT, bring a fiber optic scope. I just had a case like similar to this almost 2 years ago, and just went through the nose and in the ED. It was an angioedema elderly patient, and it went smoothly from the first time. But again, you have to have a senior person with you assisting you. You guys have to coordinate, talk to each other. I'm gonna touch base more in these things in the next few slides. Okay, so going to Manambati. I think Manambati probably is the most widely used, despite its not great specificity, and I'm gonna mention that in the next few slides. But basically, and it's get modified and people added to it class 0, but this is what is commonly used, class 1, 2, 3, 4. And basically, class 1, as you see, you are seeing clearly the soft palate, the whole uvula, the tonsillar foci, and the tonsillar pillars, and everything, right? Then you go to 2, you are seeing this, you're still seeing the soft palate. The uvula is not completely visualized. And then you go to 3, where soft palate is seen, base of uvula seen, but definitely not the whole uvula. And 4, you're not seeing even the soft palate. Then we'll talk about temporomandibular joint examination. This is something which is, I see often get missed, but it's very important, and I will show you why it's very important. So there are 3 tests you should do for the tubulomandibular joint plus the mandibular distance. I'm going to mention that. So first of all, this is, you're just palpating the joint. As you see, you're putting your middle finger just underneath the ear behind the mandibular joint, and you're touching the joint right here and asking the patient to open her mouth or his mouth, and you feel for any click, any dislocation, any limitation. And it's important to distinguish whether this limitation due to TMJ joint disease or masseter spasm, for example. They are completely different entities, and the management will be different. Then the second test, which is called the 3-finger test, where you basically ask the patient to insert 3 fingers on his or her mouth. Normally, the adult should be capable of inserting at least 3 fingers, which correspond to a range of, on average, 5 centimeter. You can say 4 to 6 centimeter, but let's say an average 5 centimeter. If the patient cannot do this, then you have a limited mouth opening, then again, you need to know whether that because of masseter muscle spasm or a joint disease. Then the third test, which is called the upper lip bite test, or in some references called the mandibular protrusion test. Very simple test. Basically, this is the vermilion, the vermilion border. So you ask the patient to bite the vermilion, the upper lip, and you observe where the incisor reach. So if the incisors, lower incisors, of course, reach beyond the vermilion border, then this is class 1. If it just touch the upper lip but doesn't reach to the vermilion border, then that's class 2. And if it doesn't reach the upper lip, then this is class 3. Next, we'll talk about other measurements. Here specifically, we're talking about thyromental and sternomental distances. And by the way, this is Dr. Durbin. He's one of the attending who trained me during my residency, and he is specialized in critical care. He's one of the popular critical care physician. He retired during my residency, but he has a lot of good publication, and he's an expert in his field. So simply you can do again a 3-finger to assess the mandibular space, the thyromental distance. And if the distance more than 3 fingers, then 3 or more, then this is reassuring. If it's less, then this is a red flag. Next, we're going to talk about the neck movement. This is very important. Under normal circumstances, the cervical extension is possible at the atlanto-occipital joint. The angle can, let's focus on this. The angle can be readily estimated at the bedside by asking the patient to sit straight up with the head erect and the line of the side parallel to the ground. Then ask the patient to open wide. In this position, the occlusal surface of the upper teeth are horizontal to the ground. On extending the atlanto-occipital joint, the angle created by moving the occlusal surface is estimated. You can use genometry here, but also you can just look at it. If it's basically 0, it's not moving, then that's a bad sign. If it's 35 or more, that's a good sign. And you also can ask the patient to touch the chin to the chest, so that's a full flexion movement, and then do a full extension movement, and look at the sternomental distances. This, of course, will be limited if you have atlanto-occipital disease, whether it's subluxation or whatever, or you have a neck fusion surgery or neck pain. So it's very important to know this before you go in and just do DL, and you want to know where the patients start to experience some pain, because you don't want to go beyond that angle and cause problem for the patient. Then next, here we have the neck circumference. So basically, this is measuring the neck circumference at the level of the cricoid cartilage. You will see in the literature there are multiple cutoff points, like this reference, for example, mentioned 33 centimeter. I've seen another reference 37. So there is really no consensus, like what's like the legit uh, um, uh, cutoff. But you get an idea. And other people took this even farther and divided the neck circumference over the thyromental distance and said, okay, if the ratio more than 5, then this is a good predictor of difficult intubation. And while you are doing this and examining the neck, it's important to look for any previous scar, any fibrosis due to radiotherapy, like if the patient had laryngectomy and they receive radiotherapy, they often have like fibrosis in the platysma, and this is usually associated with difficult intubation. Also, look for any abnormalities at the back of the neck, not only in the front of the neck. So this is called the buffalo hum or buffalo neck. It can be associated with multiple disorders, for example, the Cushing syndrome, for example. I remember I do have one of these patients, and it was extremely difficult intubation because basically you cannot extend the neck. So you have to go either by video laryngoscope or fiber optic intubation, but please don't underestimate these patients. Then here I want to tell you, when we say difficult intubation, what do we mean by difficult intubation? So most references, they define difficult intubation as grade 3 or 4. And I'm going to explain that in detail now in the laryngoscopic view. So you put the laryngoscope and then you get this view, then you grade based on that. So this is called laryngoscope grading view, or Cormack-Lehan classification. The original Cormack and Lehan system used to be from 1 to 4, then get modified and they added 2A and 2B. So the only difference here in 2, they just split it to A and B. So grade 1, you have a full view of the glottis. So this is grade 1. You see the glottis, the vocal cord, everything looks nice and clear. Then grade 2A, partial view of the glottis. You still can see the vocal cord, but it's not the whole vocal cord. Then grade 2B, you see only the arytenoid or the posterior part of the vocal cord. As you see, you just see the arytenoid right there. So then grade 3, you only see the epiglottis. You don't see anything from the glottis. And grade 4, you basically don't see the glottis or anything. So classically, most of the studies, when they say difficult intubation, they are referencing to grade 3 and 4. Then, so okay, now we did all this evaluation. Can we predict a difficult airway? Can we do that? So this is a very recent study from a well-respected journal, the JAMA, and it's a very well-conducted, in my opinion, meta-analysis where they included 62 high-quality studies with over than 33,000 patients. The incidence of difficult intubation in this meta-analysis was 10%. So again, most of the studies, they defined difficult intubation as Cormack-Lehan grade 3 or 4, but some studies, they adjust that definition and add to it the number of attempts, basically more than 3, and whether you used an advanced device or not. So, okay, then what are the physical examination findings that best predict a difficult intubation? So I want you here to pause the video and try to guess. And then once you pause the video and think about the test or the evaluation that I showed you in the previous slides, then resume the video and let's see if you get that right or not. Okay, so number 1 was class 3 upper lip bite test. If you have a class 3 upper lip bite test, that means your positive likelihood ratio is 14. And I want to here to just deviate from my topic and explain to you a little bit this terminology, because we often see them in the literature. And I think it's important for anyone to know the basics of this. So likelihood ratio, basically we have positive and negative. Here we are interested in the positive, and I will let you know why. So positive likelihood ratio, basically it tells you how much to the probability increase of having the disease given the test is positive. And basically it's a ratio that divides the probability of a person with a condition tested positive, like true positive, divided by probability of a person without the condition test positive, the false positive. So it's the probability of true positive divided the probability of false positive. And what it means, so for example, here we have the positive likelihood ratio is 14. It means that this patient with class 3 upper lip bite test has 14 times more likely to have difficult intubation than those with negative test. And then in the same context, we have here specificity. So specificity is the true negative rate. It measures the proportion of actual negatives that are correctly identified as such, while sensitivity, on the other hand, is the true positive rate. It measures the proportion of actual positives that are correctly identified as such. So then here's the question. So in this situation, would you be interested to have higher sensitivity or higher specificity? I mean, you can cheat here and see they reported specificity, so the answer is specificity, but I want you to think about this and think why I'm interested in specificity here. So think about this. Would you rather take a test that make you overreact or take a test that make you underreact? Well, the wise answer is the tests that make you overreact, which means I am willing to take more positive. I am willing to take more false positive than taking more false negative, right? So this is why I am interested in specificity, because I want a higher rate of true negative. So if this test, if this specificity, for example, 96% tell me this will not have, if it's not positive, will not have a difficult intubation, I am more reassured. But I'm okay if the sensitivity is low, because I would like to be over prepared than under prepared. I hope I explained it well, and I'm sorry if I confused you. But the next one here is the Wilson score. So what is Wilson score? Wilson score is a score that was developed by Dr. Wilson back in 1988, which basically include five parameters: weight, cervical spine mobility, impaired jaw mobility, retrognathia, and receives and the teeth, the lower teeth. Then for each one of them, you give a score, and basically what this meta-analysis showed, if you have a score of 4 or more, then your positive likelihood ratio almost 7. While if your score is less than 4, it's useful to exclude difficult intubation. And again, here we're talking about difficult intubation. 3, short higher mental distance. I remember that's the positive likelihood ratio about 6.4. Retrognathia, which is a mandible measured from the angle to the tip of the chin, less than 9 centimeter, that's around 6. And then, surprisingly or not, modified Mann-Batty score came after them with a positive likelihood ratio of about 4. This is, I don't want to scare you with this table, but basically this is the table that summarize the whole result. So I'm just gonna pause here for a second. I will ask you to look at this table. So basically this table ranked the test from the top to from the top to the bottom, again based on the positive likelihood ratio and specificity. So again, if you look here, Mann-Batty was way down on the rank, and but the point again that you cannot really depend on only one exam and say, okay, I'll just do this one exam and it will predict the difficult intubation. It's really more about multiple examination. And then here we'll shift gear and talk about predicting difficult mass ventilation. When we talk about predicting difficult mass ventilation, first of all, we have 4 grades of difficult mass ventilation. Grade 1, mask ventilation was readily achieved. Grade 2, mask ventilation was achieved but required either an airway or airway to open up the to help with mask ventilation. Grade 3, in top of the airway, you really need a muscle relaxant, otherwise you cannot ventilate the patient. In grade 4, mask ventilation is impossible. So as you see, different studies came up with different predictors, but you will see there are a few things in common between these studies. For example, if you have a patient with beard, obviously obese patient, edentulous patient, patient with history of snoring or OSA. Some people also found Mann-Batty 3 and 4, and some people found the jaw protrusion, for example, if you have a restricted jaw protrusion, can also cause difficult intubation. So I'm not going to go over this on details, but this is a summary to what I call them a green light findings. So you can pause the video and go over them. And in the other hand, you have a red line science or finding. If you find them, you are most likely will encounter difficult intubation, so you better be well prepared. For those who like abbreviations to help them in memorizing things, I summarized, I bring here for you multiple abbreviations for different things. Again, they are not optimal, but they can help you to memorize few of these tests. For example, the MOANS stand for mask seal, obesity, age, no teeth, snores, and this is for difficult mask ventilation. Then here you have the lemon for the difficult laryngoscope and intubation. And then here you have Rhodes, and then here you have short for cricotomy. Okay, and now let's shift gear and talk about basic equipment. So what are the basic equipment you need? You're going now to intubate, whether in the OR, but mainly outside the OR. You need to make sure you have all of these things. Oxygen source, monitors, oxygen delivery system, airways, mask, equipment for endotracheal intubation, suction, tube holder or tape, CO2 detector, stethoscope, and etc. So here I will go briefly over some of these equipment. So this is, of course, the nasal cannula. This is a nasal cannula with a capnography. And this is a simple face mask. This is actually partial non-rebreathable face mask because it has an oxygen. If it's without an oxygen, then that's a non-rebreathable face mask. And then this is the bag mask ventilation, or the BMV. And the reason why it's important to distinguish between them, because each one of these is capable of giving you different FiO2. So if you go to the patient and you see the patient, for example, on nasal cannula versus partial non-breathable face mask, that will tell you how hypoxic or high hypoxemic this patient, and will tell you how much time actually you have. Then this is the airways. You have oral airways, you have nasal airways, they're also called trumpets. And this is the classic ET tube. Again, you will see different types and shapes of ET tubes, but the principle is the same. You need to secure the airway. This is why we call this is a secure airway. And you have the cuff below the vocal cord, and this mark, typically it should be at the level of the vocal cord. Again, it's important to know the difference between the ET tubes and what is available for you. And you see this is the radio oblique blue line to appear in the X-ray. Then LMA, you have tons of LMAs. This is the unique LMA, Supreme, Fast Track. These are called supraglottic device, or in some countries they call them extra glottic device. stylet, bougie. Bougie is something very cheap but very, very valuable equipment, and it's a very important equipment, especially when you are dealing with uh, grade 2A and 2B, mainly B actually, and even 3 uh, difficult intubation, because he literally can pass this below the tip of the epiglottis, and you feel it when it touch the tracheal cartilages, and then you slide the tube over it. So emergency airway box or kit or bag or whatever you want to call it, but I highly recommend that you have such a bag, especially if you are going to intubate outside the OR. So what you should put in this bag, this is, of course, face masks of different size, airway, oral, nasal, laryngoscope, different plate size, ET tube, uh, and I would make sure that I test the balloon of the ET tube, put the stylet in, be prepared. And for pediatric, I would also add uncuffed tube. Uh, it's not that common, but every now and then you will go to intubate someone in the pediatric ICU or in ICU, and you will realize that even size 3 cuff tube is big for that baby, so you need a smaller tube. Then LMA, bougie, of course, excited CO2 detector, a stethoscope, some basic drugs for anesthesia and muscle relaxant, and of course, vasopressors. Then a backup emergency here, I recommend having the cricothyrotomy kit and tape, syringe, McGill forceps, tongue depressor, and lubricant. And remember, this is not a difficult airway cart. If when we talk about difficult airway cart, then we're talking about more advanced equipment that include fiber optic scope, video laryngoscope, and more advanced equipment. So speaking about advanced equipment, I'm gonna just briefly go over them, but here is the key. So from here on, you must make sure that these are the things that you definitely want to have a workshop to know how to use them. You need to have simulation sessions, and these things need practice. You cannot just watch this video or do a couple of cases and you feel that you are prepared to deal with such difficult intubation with this equipment. So there are a bunch of them. As we see the supraglottic devices, we have a plenty of options now. Many of them help you with intubation. And we have also infraglottic devices, which is basically has a double lumen tube, one to go in the esophagus and one to go to the airway with double balloons. Then we have a newer laryngoscope, blades, handles. We have stylet, we have video laryngoscope, and fiber optic laryngoscope. The video laryngoscope, there are plenty of them. I use the glidoscope, I use the CMAC, and for the fiber optic, as an anesthesia provider, most of us we like to use the flexible fiber optic. The rigid mainly used by ENT, but you may need to use it at some point. But I'm very confident that you can do almost everything with a flexible one if you know how to use it. Then briefly we'll go over surgical options in airway management. Again, I highly recommend you need to attend workshop and do simulation for this. So here we have basically the cricothyrotomy, retrograde intubation, the tracheostomy. Mainly we're talking about the percutaneous dilational tracheostomy. So this is, for example, a kit for cricothyrotomy. And if you don't have a kit, basically all what you need is a 15 blade knife to open the ligament, and a very small tube or even a needle. So the steps are very simple, but again, you need to do this. You can use a syringe, go through the cricothyroid ligament and look for bubbles, then slide the catheter, then after that you have the guide wire, then you dilate, then you put the dilator, then you replace it with the cannula, and you can oxygenate and even use jet ventilator. For the tracheostomy, obviously you go lower in the trachea. Ideally, you would like to go below the second tracheal cartilage. And here, if you are in an elective situation, you obviously need to have a bronchoscope or fiber optic scope to help you from above. And nowadays, we've seen ultrasound coming to the use to help you. And I participated, I was a co-author in a chapter where we explained how to use ultrasound for percutaneous dilated tracheostomy. So feel free to reference to that. Here, again, the same principles. It's a Snyder technique. So you go by a needle, then a catheter, then a wire, then a dilator, then the tracheostomy tube. Complication of airway management. The reason why I put this table here, I try to summarize the complication that can occur during intubation or after extubation. The take-home message that this is not a benign procedure. You can have complication with this. In fact, if things goes bad, you might lose a patient. So I want to stress on the fact that don't take this lightly. It's not just about putting a tube in. It's about understanding the whole process and how you deal with complication, how you avoid complication. And when you go and consult consent a patient, please be clear with them, and don't forget to mention the potential complication, especially trauma to the teeth, to the lips, even to the eye. It's not 100% benign procedure. So speaking about difficult airway management, here, again, the key that you have to be prepared. I'm going to show you a bunch of visual aids during the next few slides. These are things that you can print, you can put it in your pocket, you can put it in the OR, you can put it in the airway cart. But the key that you need to review them, you need to practice them in a crisis management simulation scenarios. You need to be comfortable with them. When you have a difficult airway management, there is no time to pause and think or search about what should I do next. You have to have this in your mind, and you have to have this is clear and systematic in your mind. So just to motivate this discussion, I want to tell you about this patient that we had a few years ago. And this is known to be the heaviest man in the world, at least at that time. We published that as a case report back in 2014, but basically the case was done in late in 2013. So when we had a patient to the hospital, the firefighter had to um, bring the patient, and they weigh him, by their devices, and they found he was 610. So they reported that weight. If you are interested in this story, it had a lot of media cover at that time. You just Google it, or you go and read the case report that we published. And then the patient admitted to the hospital. He spent about 2 months before he come to us in the OR, and they put him in a comprehensive weight losing regimen. So when he came to us, he was like 510. As you see, there was a lifter involved here, and there was a special bed and special equipment. So here we go. We have the patient, and this is just to show you the airway. So this is, as you can see, I would call it Manambati 4 because I don't even see the soft palate. The neck circumference was 42 centimeter. The thyromental distance was, I would say more than 3 fingers. It was not bad. Mouth opening was okay. Neck movement was okay. As you imagine, with this birdie habitus, you really cannot have a full neck movement. And then here we go. If you want to make this as fun, you can pause the video and think what you would do in this situation. Then I will take you and I'll show you what we did. I was part of the team at that time, and I was a junior resident. But again, the key for these patients, and I also have a review article, how to, what are the consideration for obese patient. You can find it in Google. But the key for this patient is position. So this is what we did. So that's, as you see here, that's December 4th, 2013, just around 8 a.m. So this is a video laryngoscope. We used a glidoscope. This is the tongue, and this is the grade. I would call this almost grade 1, but as you will observe now, it goes back and forth between grade 1 and 2B. It mainly depends on how you hold the blade. Here comes the tube. The tongue was an obstacle, was a challenging to go around that big tongue. And then going through the glottis. And here you go, the stylet is, watch the stylet coming out. Yeah, right now. Yep. So it went smoothly. So then obviously you have to have a difficult airway algorithm. Maybe many of you are familiar with the ASA difficult airway algorithm, but I decided to use this one because I feel it can be more applicable to situation outside the OR. But the concept is the same. So this is the DAS, the Difficult Airway Society. They published their guidelines in 2015. And they divided their algorithm to 4 plans. Plan A, which consider face mask, ventilation, and tracheal intubation. So you put the laryngoscope. If you are successful, you intubate the patient, that's it. If not, you failed intubation, then you go to the next level, which is putting the supraglottic airway. And this is again the same as like the ASA algorithm. So LMA comes the next step if you cannot intubate. Here, if you are in the OR and you cannot do that, then you go down the road to either wake up the patient and figure out something else, or go down the road of surgical airway. So if you cannot ventilate, then all what if you cannot ventilate with the LMA, then basically all what you end up is the face mask ventilation. So if you cannot do that, then you are at the level of what they call it cannot intubate, cannot ventilate, or cannot intubate, cannot oxygenate. And then at that level, you need surgical airway. The most easy performed and fastest, I think, is the cricothyroidotomy, especially if you don't have an ENT on board. So this is the same algorithm, but with more explanation. So again, I cannot emphasize enough about the importance of positioning. Shoulder row, head position, neck position. Pre-oxygenation is extremely important. It buys you times to do many things. So pre-oxygenation is very, very important. Do not underestimate the importance of pre-oxygenation. Take your time, especially if you are expecting a difficult airway. This extra 2-3 minutes while the patient can sustain apnea, they are very important for you. Then you can paralyze the patient. Again, there is a lot of debate. Should I paralyze the patient? Should I not paralyze the patient? I personally think if you think this is a difficult intubation, then you probably want to go with short acting muscle relaxant. Then do not do more than 3 attempts. Please call for help early on. Know your limitation. There is no shame here. You are saving life. You have to have your bougie, and then if there is someone doing a cricoid pressure and it's a difficult intubation, it's okay to remove the cricoid pressure here. You need to save life. Again, this is the second step. So you have multiple generation now from the LMA, and be thoughtful. Why you could not? Why the LMA didn't work? Was it small? Was it big? Do you need to change the size? And then, if you cannot bag the patient, most of the time it's related to position. So please hold the mask with 2 hands. Ask for assistance. There is no shame. Some patients, they are just difficult to face mask bag them. So it's very important to be quickly moving on this procedure. Then if you need to have that, if you don't have, again, if you don't have the percutaneous, all what you need is a scalpel and do this. And this is the scalpel cricothyroidotomy, basically blade size 10, sorry, tube size 6, and bougie. So you put the blade, open, insert the bougie, slide the tube over the bougie. And before that, you see here mentioned the laryngeal handshake to identify the cricothyroid membrane. So because you're gonna go through the cricothyroid membrane. And here it takes you through the steps, how you put the blade, how you rotate it, how to dilate, and how to, and if you cannot palpate the thyroid membrane, you can basically make 8 to 10 centimeter vertical skin incision, caudal to cephalad, and you just basically you go blindly. Here you're talking about seconds you need to save the patient. So let's switch gear here and finish this talk about ICU patient. First of all, why ICU patient are different? What's unique about ICU patient? From my experience, and probably many of you, intubation in ICU is more challenging than intubation in the OR for multiple reasons. You have sicker patient, suboptimal, place. Position is challenging. You don't know the people around you. You don't have all the equipment that you need. You don't have access to everything you need. So the key here to be really prepared, and you have everything handy, and you communicate before you start the process. So again, pre-oxygenation is very important, especially if you have some time. Be thoughtful about the hemodynamics of the patient. You don't want to have a cardiac arrest after or during your intubation. Assign the team members. Here is a specific prediction tool for difficult airway in ICU called the Makusha score, which basically 7 parameters, each one assign them a score. Then you sum up the score, and if it's more than 2, you need to have a senior anesthesiologist. And then there is a other thing here we often hear in the ICU called the physiologically difficult airway. Physiologically difficult airway patient, they are hypoxic, they are hypotension, they have severe metabolic acidosis, they have a right ventricular failure. I cannot emphasize enough about the importance of making sure if you are going to the ICU, please ask about the heart function. If you have a patient with right ventricular failure or low ejection fraction, you have to be very, very careful with them. I personally don't have any case, but I have heard about cases that patient develop cardiogenic shock after intubation. So you have to be very thoughtful about that. Now positioning, I like ideally this position where I come from the head of the bed. Make sure you have your assistant having the tube ready to go. You have the suction, everything. We'll go over the checklist now. But position the patient where in a position that make you comfortable. I mean, if you go in and you enter the room and they're doing a CPR, that's a different story. But position is very important. And remember, at the end of the day, sniffing position is your friend. Then go over the pre-intubation checklist. And this is not only applicable in the OR, but anywhere you go. Do you have a functioning suction? Do you have everything you need? You go over them. And this table summarizes some of the medication and doses, especially in the ICU. So for example, here we have a sedative, hypnotic drugs, neuromuscular blockers, vasopressors. I would say there is no rough rule to what you give and how much you give. This is all depend on your patient. So if you have a patient with cardiogenic shock or ejection fraction of 20, septic shock, then please be very thoughtful about, especially please don't go and push 100 milligram propofol. Please don't do that. You may even believe it or not, even if you don't use propofol and you just depend on midazolam, which obviously you need to give a higher dose in this situation, but that's fine. Your patient will be intubated for a long time, even if you give 5 milligram or 10 milligram. Um, but the thing that once you relax the patient, the blood pressure will drop. Because usually you have an agitated patient, then you give anything from this list, then the blood pressure will drop, no matter what you choose. So I would definitely make sure I have it in my hand ready, vasopressor, mainly norepinephrine, or if you don't have norepinephrine, phenylephrine. And if you are really expecting that this patient blood pressure will drop, so I would push norepinephrine and midazolam or propofol together. And of course, have your sedation bag and your pressor bag ready to go. And don't leave the patient after you just put the tube in. Stay with the patient for a few minutes to make sure that the patient is hemodynamically stable. Okay, I will finish this talk by briefly talking about COVID-19 patient. The key for this patient to be properly wearing your PPE. So it's very important to know how you do the donning and the doffing and which consequences. Basically, you need to have your gloves, your gown, your N95, or the FFP3, they call it in Europe, the goggles, and then the gloves. And you remove them in the opposite order. Before you go to the room, make sure you are fully covered and protected. Protect yourself before you do anything. This is an example of anesthesiologist or anesthesia provider doing intubation. They're using video laryngoscope. They are fully covered and protected. And then this is a scheme to show you where to stand, where your assistant to stand, whether you are in the OR or in the ICU or anywhere. So the first rule that people who has nothing to do with intubation, they should stay outside the room, or at least more than 1.5 meters away from the patient. Then here's the person who will intubate, the assistant here. As you see, they all fully protected. And then visual aid. Again, I cannot emphasize enough on how important having visual aid for us. If you are interested, you can go to the reference and download it or take a snapshot or whatever. But basically, this is a very beautiful visual aid, literally just published. It's summarized to you what you need to do outside the room, inside the room, and after leaving the room. So it goes through the checklist of personal protective equipment, allocating the role for the team, prepare your equipment, having everything you need, medication, everything planned, then prepare for difficult intubation. What's your plan? If this doesn't work, what you're gonna do next? Then inside the room, quickly assess the airway, put the monitors in, check your IV. It's very important to check your IV before you give drugs. And then optimize position. Again, this is very important. Pre-oxygenate, treat blood pressure. Do you need to give fluids? Do you need to suction the NG tube? Do you need to, what do you need to do? Then you put that tube in, you inflate the tube, you test the tube, make sure everything okay. Then once you leave the room, remove your PPE and the consequence that I mentioned before. This is very similar to the difficult airway algorithm that I showed you a few slides before, but adjusted or modified for a COVID-19 patient. But again, the key to have your PPE, remember to call for help early. And this is again the same for the crick, what you need to do. And after you do the surgical airway, what are the things that you need to do? and like the recruiting maneuver, check the chest X-ray, and etc. And this is the final slide. This is just a concept, and it's not really an algorithm. It's the vortex concept. So every time something fail, like face mask fail, go to the next step, like intubation fail, uh, go to the supralaryngeal fail, then go again and again and again and again. The idea to save the patient life. And remember, just adjust few things. And do you need to adjust the position? Do you need to change the side? Do you need to suction? Do you need to give muscle relaxant? And remember, even this is a proper way to hold the mask, but sometimes it doesn't work. You need two hands and you need someone to help you back with the patient. So keep that in mind. And that's all what I have for you to do. Thank you for um, staying with me to the end. This is our YouTube channel, and feel free to visit the channel and see the other videos, the other lectures that I recorded and my colleague.